without fiber, without delivery system in the world. In this chamber is situated the laser, and there is a very simple transmitting system of mirrors that reflect the beam. And there is no optic, there is no fibers, there is no limitations of the other lasers.
Before I'm going to break it, I'll hand it back to you. Thank you very much.
No, you can. You will not break it. There is no optic.
Well, welcome on stage, Dr. Georgi Tomov.
Thank you very much. I'm very pleased to welcome you. Now we are going to talk about one really wonderful device, ergonomic laser for cavity preparation and for soft tissue also treatment. This lecture is dedicated only to hard tissue, but in Thursday you are invited on the second lecture that is dedicated on laser surgery. But nowadays the topic is the cavity preparation. Why I decided to start with this topic? You know that nowadays in the world there is a great interest for laser, and this great interest is because dentists and patients both want to avoid the rotary system for cavity preparation, that great source of fear. And this replacement now is possible with ergonomic lasers. To talk about the laser family is a big deal, and now I'm going to mention the major lasers on the market. You know that the major lasers are carbon dioxide laser, diode lasers, and ergonomic lasers. The first one, carbon dioxide and diode lasers, are preferably used for soft tissue surgery. Then the ergonomic lasers are used for both soft and hard tissue treatment. Laser devices use a variety of physical media as a source of generating different wavelengths that interact with the tissues, and the major point is what wavelength we need. So to decide what to treat and how to treat it, we have to know some basic on laser physics. This is a very popular chart, and you can see the absorption curves of various tissue components. You know that in the soft tissue there is a melanin, there is a hemoglobin. In a hard tissue there is a hydroxyapatite, there is water also. And when we see this chart, you can see that water is the component that is mostly absorbed by ergonomic lasers wavelength. This is 294 nanometers wavelength. And for this reason, with ergonomic laser, we can treat almost all teeth that contain water, soft and hard. I would like to discuss some details about the ergonomic technology. Mostly available ergonomic lasers use a fiber delivery system, and this is due to their limitations. What are the limitations of this fiber delivery system? In fact, we lose, with these optic fibers, we lose 30 to 45% of the energy, and this is weaken the laser power effect. And what is more, this fiber delivery system are breakable, are fragile, and expensive. So it is overcost. The development of laser technology, you can see that the first one are carbon dioxide lasers, then the diode, then the ergonomic family, and nowadays we have the first laser, ergonomic laser, without delivery system. And the designers of LiteTouch place the laser here. The laser is here in this chamber, and avoid the optical system. This is delivery system for electricity and for water. The laser is placed in this chamber, and we have a system of mirrors, reflecting mirrors that reflect the laser beam. This is the chart of the laser inside. You can see this is the first all-tissue, non-fiber, non-articulated arm ergonomic laser known as a LiteTouch. This is very suitable for clinical use because there is a great maneuverability and you can turn it in different directions. Very good for clinical use. We also provide multiple tips. And these tips are short and long with different diameters, and this is due to their indications for hard or for soft tissue treatment. And what is more, the software of this laser is advanced. There is a two-program, hard tissue and soft tissue program, and because the topic of nowadays lecture is dedicated on hard tissue, you can see this menu of hard tissue. We can cut enamel, we can cut dentin to remove the caries, to perform etching, laser etching, and also when we can perform a bone surgery when provided some periodontal surgery with open flap, and also to remove the calculus from the teeth. So, what is the scientific background? There is some very important facts that we have to know about laser when we choose laser, and if I have to summarize the ideal laser, it could be to the following Leonardo criteria. The laser must have a low energy intake in dental tissues in order to avoid overheating and any temperature changes. Laser, when we treat hard tissue, must etch without acid. To have optimal ablation rate, that means to remove effectively the tissue, no overheating and no vibrations. Laser must possess antibacterial activity to avoid any additional medication for the cavity, to reduce the pain sensation or to avoid the pain sensation, to remove the debris and not to produce the smear layer like the burns, and of course to be compatible with other oral tissue. So I think that this laser is according to the Leonardo criteria, absolutely. So the basic physics of the lasers. You know, this is the interaction with the tissue. Some of the energy are reflected. This is the energy loss, and some of the energy is absorbed and or pass over. This absorption can produce different process in the tissue, heating, photochemical effects, photoablation or photodisruption, fluorescence, ionization, etc. But we are interested about laser ablation. This is the phenomenon of removal of hard and soft tissue from treated area, and this laser ablation is due to water content of the tissue, because this wavelength interact with water molecules, and water molecules evaporate, and this micro-explosion lead to removal of the hard tissue. And on this 3D chart you can see this is a cavity prepared with a laser. Of course the absorption depends on different factors: wavelength, the content of the tissue thickness and ray penetration, superficial humidity is for the best cutting, the ray angulation, contact or non-contact interaction, and exposure time. Here on this chart you can see my explanation in pictures. I'm sorry, this is not in English, but I will explain. You can see this is the chart that represents the enamel. The enamel is contained of biological hydroxylapatite, protein matrix, and water molecules. When we treat the area with laser, the water molecules explode. They contact with this laser energy and then explode. And the superficial layer, we have the ablation. This explosion leads to ablation, to distraction, and we remove tissue. In the middle area there is a small changes in the crystals, but we do not remove, and in the deep layer there is remain intact. So the first point that is very interesting for us is the thermal effects of laser on hard tissue. These thermal effects could be dangerous if we use laser without proper water cooling. from 37 to 50 degree we can provide hyperthemia. To 70 degree we provide the coagulation of the protein and denaturation. To 80 degree there is a melting of the tissue, and to 150 degree we provide ablation and evaporation, and over 200 degree we do carbonization of the tissue. These are undesirable thermal effects. And you can see on these pictures, this is SAM photos, these undesirable thermal effects when we use laser without water cooling. On the upper picture you can see this melted, it's a glass-like tissue. This is the crystals of the enamel that is melted, and when it's cool, you can see this melted tissue, glass-like tissue. On the second picture, you can see the dentin, human dentin, that is also overheated, and this is carbonization of the dentin. These are undesirable effects. So, firstly, before to use this laser in our practice, because I'm a clinical assistant professor in the university, we wanted any scientific evidence that this laser do not damage the heart tissue. And we provide different experimental studies, and one of these experimental studies was to compare the temperature changes after laser preparation and after preparation with other rotating instruments. These are the groups: ergonomic laser LiteTouch, the program heart tissue, steel bursts with micromotors, and diamond bursts with air turbine. This is the experimental design. We put a thermocell into the pulp chamber, and this thermocell is connected with the thermometer, and then we prepare the tooth and evaluated the temperature changes. What are the results? You can see when we minimize the water cooling or switch off the water cooling, the temperature is increasing up to 15.2 degrees. This is high, but when we use this laser according to the manufacturer's instruction with proper water cooling, the temperature changes is not more than 3.2 degrees. It's same like when you're drinking coffee, hot coffee. To compare with the other groups, you can see the micromotor, the temperature changes is 0.8 degree, and the air turbine with water cooling, the temperature changes is 2.0 degree. So the three systems that we know for removing the caries, for preparing the cavity, are safe for the tissue if they are used in a proper manner. The second investigation was dedicated to morphological changes in hard dental tissue when we treat with laser. We use a natural human teeth that were extracted due to advanced periodontal disease, and this natural teeth contain natural carious lesions, and we treat them according to the protocol. We use also steel burrs, diamond burrs and air turbine. We use in the group 3 Carisol gel. You know Carisol gel, it's a gel for chemomechanical preparation of the caries. And the 4th group was ergonomic laser. These are the groups treated. This is the Carisol gel for chemomechanical preparation, and the laser hard tissue program. Half of the treated teeth were obturated, then filling with filling material to evaluate the bonding strength and to evaluate the bonding area, and we also evaluate the marginal adaptation of this filling according to this criteria. The score of the marginal adaptation, and the half of the other teeth were evaluated by SAM for the great magnification for this method for evaluation in order to explain our result. This is the first group when we treat with diamond burrs. You can see there is a smear layer. Smear layer cover all the cavity. There is no distinction between enamel and dentin. There is no visible any tubulous orifices open. All the cavity is covered with smear layer. And for this reason, when we prepare the tooth for adhesive protocol, we use different etching agents to remove this smear layer. This is for first group. Of course, there is a poor marginal adaptation, especially in the cervical third, and this poor marginal adaptation could be explained with this very thick layer, adhesive layer. You can see on the upper side is the composite material, this is the dentin, and this is the border. This is the adhesive interface between the dentin and the adhesive, and you can see there is on the grade magnification there is a gasp, there is a spaces, and for these reasons sometimes we have recurrence, we have additional secondary caries, we have hypersensitivity in some cases when we use this protocol. For the second group, you can see the results for the turbine preparation. Because of the cooling water, there is some kind of a turbulence, water turbulence.
What was the name then?
Okay. Smear layer is removed, but there is also remnants. In some pictures you can see the orifices of dental tubulus, but in the other you can see it. So we still have remnants. Also, the marginal adaptation was not perfect, and you can see the spaces and the gasp between the two layers. In this group, this was very interesting. The surface was very retentive and very clear, but when we evaluate the marginal adaptation, it was the poor marginal adaptation in all evaluated group. Why? Because this carisol gate contained sodium hypochlorite, and you know that sodium hypochlorite release chlorine and release oxygen, and this chlorine and oxygen both can interfere the polymerization of the bone. And for this reason, despite of the clear surface, we have this connection between the dentin, the composite material, and the bonding agent due to the sodium hypochlorite. And on the last group, when we treat tissue with laser, you can see the surface are very retentive. This is good for bonding. And also there is no remnants. There is no remnants because there is no cutting. We have a micro explosion, and this micro explosion leads to this very retentive and very clear surface. This is the dentin that is treated with a laser. These are the enamel. You can see this is the typical characteristic of the enamel, the rods of hydroxylapatite, but there is no remnants, there is no smear layer, and the surface is very clean. The marginal adaptation, of course, it's not perfect, not absolutely perfect, and you can see on the cervical portion that there is a small dye leakage, but was the best comparing with the other groups. And here you can see the interface characteristic. In fact, there is no distinguished border between the enamel and composite material and the dentin and the composite material because of the retentive surface and because of the absence of any smear layer. So if I have to summarize these results, we have some advantages of laser ablation versus to conventional drilling. We have effective ablation rate and micro retention, selective caries removal, selective because the carriers contain more water, and this water is there is a communication with the wavelength of the laser. There is an optimized adhesion and adaptation of the filling material. There is no thermal or chemical damage of the dental tissues, lack of smear layer, and also antibacterial activity. This is important because due to this antibacterial activity of the laser, we can avoid any additional medication of the prepared cavity. Because you know that the additional medication can provide a pulpal irritation, influence over the polymerization, and also they possess insufficient antibacterial effectiveness. So what are the clinical implications for caries removal, for cavity preparation, enamel etching, enameloplasty, excavation of pit and fissures for placement of sealant, and to decontaminate the exposed root surface when we have any recession, gingival recession. So we evaluate also the clinical aspects of this laser, and we treated 30 patients, 83 cervical caries lesions are vital did without anesthesia, and we assessed the same criteria: average clinical time for preparation, cavity medication, the adhesive protocol, the filling quality, and the patient comfort during treatment also. You can see this is a typical case, cervical caries. This is very painful situation when we have to treat with any burrs, and usually we have to put anesthesia. In this case, we don't need to perform any anesthesia. We treat with laser without touching, in distance at about 2 millimeters, and there is no vibration, there is no pain sensation. You can see the treated surface when it's blow up with air. You can see this frosty appearance of the enamel. It is very similar in clinical appearance like acid etching, but there is no any acid etching. We apply the adhesive agent without etching and the final restoration. So the results are that the clinical time for preparation, the average clinical time is about 10 minutes. Only one of the 30 treated patients reported for pain, and it was necessary to provide additional anesthesia because the caries was very deep and near by the bulb chamber. According to the USPHS criteria, the quality of the fillings was excellent, and no one reported for post-operative sensation. This is also very important. So this is the other application of this laser for hard tissue. Here, discussing the enamel etching, you can see on the left picture, you can see the intact emile and the enamel treated with laser. The surface is very retentive, and you can compare with these pictures. This is taken from one Brazilian dental journal. On the first pictures, you can see the effect on etching with 37% orthophosphoric acid, and here is used a non-conditioner etchant, and you can see the differences. The major point, the major question is, do we need so severe etching? And the answer is yes, in any special circumstances. What are these special indications? Non-carious lesions, Turner's dysplasia, fluorosis, and for bracket fixation when there is a relapse and mostly removing of the bracket. This is a clinical case, a young girl with Turner's dysplasia, with bad facial appearance, bad self-confidence, and we decided to treat this non-carious lesion with laser. You can see the distance between the tip and the tooth, it's at about 2 millimeters. You can see after preparation, and we blow up with dry, you can see the frosty appearance of the prepared tooth. It is without, I confirm, without any acid etching. Then apply the bonding agent and the final restoration. Another case of Turner dysplasia, excavation as fissure for sealant placement, also the same clinical appearance. The sealant placement after this, again without any acid. excavation sealing, fissure, also the occlusal caries treatment, the procedure without acid etching, composite filling removal. It is possible with this laser because the composite filling contain any water and we can remove it. For conditioning the exposed root surfaces to decontaminate and to cover with any desensitizing agents. Non-carious lesions of hard dental tissue. It was a young vegetarian patient that consumed a lot of fruits, a lot of juices and so on, and this is a very severe erosion, very unpleasant and painful clinical situation. All the teeth were treated, and you can see on the picture number 3 that the gum is affected. This is my error. This is because when I'm beginning to treat with laser, I have the mobility and the concentration. It's pretty different from the burst, from the rotation instrument. What are the benefits? When we cervical lesions with rotating instrument, and when we touch the gingiva and provoke any bleeding, it is impossible to finish obturation in the same session because of the bleeding. But here it's not the same way because there is coagulation. The laser provides coagulation, and we can continue with caries removal and cavity preparation when we can finish the obturation in the same session. So this is the final result with this patient. What are the clinical advantages of this laser? No vibration and no driving noise. Kill bacteria, so there is no need for medication. There is no smear layer and no need for any acid. Less pain and no post-operative hypersensitivity and ergonomic and shorter treatment. Of course, there are also financial benefits because the treatment effectiveness is very high. The procedures are performed quickly. Of course, one of the most important issues is that the patient satisfaction is very high. And LiteTouch has a minimum maintained cost because there is no fibers.
But now I just want to show
breakable and expensive fibers to remove. Thank you for your attention. And I also invite you at the booth number 50, hall 4.2 to touch the LiteTouch. And you will have the ability to work with this laser, and also if you are interested in possibilities to treat surgically, to perform any surgical treatment for soft tissue with this laser, the next lecture will be at Tuesday at again at 11 a.m. Yes, according to the schedule, it's 11 a.m. Lecture dedicated to surgical procedures with this wonderful laser. Thank you once again.
Thank you, Dr. Georgi Tomov. And as you said, you're going to be with us again on Thursday, it is, I think, at 11 o'clock here.
Yes.
Maybe we would just name once again the booth of your company, which is in...
the booth is number 50, hall 4.2.
Okay, then. And on Thursday again at Speaker's Corner. Thank you very much. Thanks for being with us. Dear ladies and gentlemen, a short break, short intermission now, and we're going to have the next presentation coming up in a few minutes.